Good morning. It is January 6th. This is the Senate Health and Welfare Committee meeting. And I'd like just to welcome everyone who is out in the YouTube world with us, and then also folks who are here testifying and committee members. But before we begin, I just want to say that I have been very privileged to be involved in the democratic process for many years, first on a school board, then as on the select board, as a select board chair for 10 years, and in the Senate now for many different sessions. The value of citizen participation that we have in this state begins at the local level. And it allows for us to have agreement and disagreement in a very a collaborative way. So, and the reason I'm saying this today is we know what happened a year ago, and that I am so proud to be a part of the Vermont democratic process at the local level and at the state level, and working with folks who have different opinions, different ideas. And it's that mix that makes Vermont so special, but it's also that mix that will perpetuate democracy going forward in the future. So just a couple comments. And I did want to say that today because last year was so really appalling to so many of us. And voices can be heard. They can be heard in meetings, quietly, sharing and working together. So thank you all for putting up with me for that. So today we're going through some of the bills that we have, and I don't want to call them leftovers, but they are bills that we had wanted to look at during the whole COVID pandemic. So in that sense, they're left over as a result of the pandemic. And we have with us today Senator Wessman, the sponsor of S91, an act relating to parent-child network. And then after Senator Wessman, I'm going to suggest, Katie, unless you think otherwise, your opinion on having both Senator Wessman and Senator Benning go back to back. Is that okay with you?
That's fine with me.
Okay, good. And then in that way, I don't want to hold either one of you up from your morning obligations. So Senator Wessman, welcome, and thanks for being here.
Thank you for having me. Rich Wessman for the senator from Lamoille. I would say, first off, I may be the lead sponsor on it, but on my screen, Senator Lyons, you're in between Senator Hardy and Senator Hooker. And they're both sponsors of the bill also. So we have a good crew to support parent-child centers. I specifically in the group worked with the parent-child centers to help put together this bill. And a little history, parent-child centers were put in statute about 25 years ago now, sometime in the late 1990s. And since that time, parent-child centers have become more formalized, and amount of services they offer has expanded, and they've become a lot more integral in the delivery of services in all of our communities. Just as a reminder, there are 15 parent-child centers across the state now, and the breadth of their services, is quite expansive. They do home visits, they do early childhood services, they do parent education, they do playground work, they do parent support groups. They offer concrete supports for the whole family. They do community development work, and they do research and referral. And all of those things, this bill would hold all of the 15 to doing that center-based work. The bill establishes in statute the parent-child center network to ensure accountability among and distribute funds to designated child care centers. That's the first thing the bill does. It amends the criteria for designation as parent-child centers. Those 8 criteria would be in that portion. It appropriates base funding to parent-child center network. And I might say there's a section on funding in here that would have to be changed because this is last year's bill. We did take money, one-time monies last year, and we took some of the COVID monies and put towards the parent-child centers to help them with their work. So the funding piece might need some work. It would establish an annual inflation to monies appropriated to the parent-child center network. I think given the last few years of history going back, that the Health and Welfare Committee has been involved in some of the issues and the back and forth push on funding and services for the parent-child center. That also is part of the reason that this all came up. We some of the assessments and counseling, as you will remember, whether it should be at the state level in DCF or whether it should be in the parent-child centers a couple of years ago, was up as an issue. So the broad outline is that this more formally puts them in place and tries to put them in a place where it formalizes their relationship with the state and the partnership that has developed and solidifies all of that. And I sincerely hope that your committee takes it up. And as I said, the effective date of this bill would have been July 1st of last year. So there will be some changes in that, but the basic premise behind this is still extremely valid and I think important for us to look at.
Okay, thank you. That's terrific, and thank you for bringing this to us. And I think that we will probably go forward with the bill. We'll listen to Katie a little bit later about the details, but
Yep.
then it sounds like some of the heavy lifting is going to be done in your afternoon committee.
Well, I think, from the policy standpoint, establishing the network and the framework around that will lay the groundwork for any work that any appropriation might happen going forward in the future. And I do go back to those the assessments and the counselors that we fought back and forth what role the parent-child center should have. We need to look at all of that, and that will dictate a lot of the way the money flows.
Good, thank you for that comment. I think that is very helpful. Terrific. Okay.
And I didn't mention it, but you're the chair of a committee, and we did talk a lot about the role of the different players in the delivery of service to at-risk kids and families. And there may be a recommendation that you might speak to when we formally get a report.
We're working on that. Our final Child Care Protection Oversight Committee report coming to us soon. So this is good.
It was chaired quite well, that committee.
Thank you. We're going to come full circle. Okay. Any questions for Senator Wessman on his sponsorship of the bill? Senator Hardy.
Go ahead.
I don't have a question, Senator Wessman, but I did want to just add, first of all, I appreciate you did a great job. I appreciate your work on this bill over many, many years. And I'm glad that we're taking this up early in the session, and just wanted to also, make the connection that we did a lot of really important work last session on early childhood education, and our parent-child centers are a crucial part of that network and that system. And I think it's really important that we update their statutes and make them much more integrated into the work of the state when it comes to early childhood education and care. So thanks, Senator Wessman.
A majority of the parent-child centers offer childcare.
Yep.
And I was going to say, I am sure when I'm off the screen that Senator Hardy and Senator Hooker can answer lots of questions about this.
Of course. You know what, I don't want to let you leave without acknowledging Janet Munt, a former senator from Chittenden County, who worked so hard to actually get parent-child centers into statute. And it was really an honor to work with her when I got into the Senate. So this is a continuation of, as you said before, a long history of involvement on part of many people. So thank you.
Yes, and I can't with that can't help but mention that at that time, the present chair of Senate Appropriations was the secretary of the agency and was integral in the creation of their original. But that was 25 years ago, not to date any of us, but the world has changed.
Yeah. And the pandemic doesn't help.
No, it doesn't.
Okay, thank you so much. And I think what we'll do at this point is we're going to switch gears over to S69 and Senator Benning, and have Senator Benning introduce his bill on suicide prevention initiatives. And then after that, we'll go to Ledge Council and walk through both bills. So Senator Benning, thank you for being here.
Thank you, Madam Chair. And let me say first that I'm Joe Benning. I represent the Caledonia District in the state Senate, the Caledonia District being all of Caledonia County and the 6 northeasternmost towns in Orange County. Madam Chair, I'll start by saying I was very touched by your opening words, and I completely agree that we have a unique opportunity as Vermonters to be able to chat with each other in a calm and civil basis and do things that actually help people, which is what this particular bill is all about. I will also say at the outset that I'm a little bit out of sorts at the moment. As horrible luck would have it, I received a call during our LCAR meeting earlier this morning that one of my clients is suffering a mental breakdown, has been lodged, and I have to deal with that sometime today. So this is very timely bill, even though it was identified as a leftover bill from the previous session. I can appreciate the committees taking the time to take it up, and I do hope that you will. First, the bill itself was pretty much born in a conversation with the administration, where I said, as Republicans, we're often batting back other legislation that we don't like. What can we do that's positive? And so we sat down and came up with a series of conversations that led to these entities you now see embedded in this bill. And I'm also happy to say I'm going to up Senator Wessman by 1 and say 3 members of your committee are actually on this bill as well. So I greatly appreciate the bipartisan efforts, and we'll try to break the bill down in a short series of statements. First, there is a request for $125,000 to go to the Department of Mental Health to increase to 70% the in-state call response at Vermont's local crisis call centers. You might be interested in just hearing a list of who those call centers are, because every one of you has actually got one of these entities in your backyard. The Clara Martin Center, Counseling Service of Addison County, the Howard Center, Healthcare and Rehab Services, Lamoille County Mental Health, Northwestern Counseling and Support Services, Pathways, Rutland Mental Health Services, United Counseling Service, Washington County Mental Health, and Northeast Kingdom Mental Health Services. Those call centers are critical, and I'm going to give an example of why I think we need to increase the funding. About 4.5 weeks ago, I was sitting in my law office, which happens to be on a major corner in the town of Linden. My office is actually on the ground floor. My sign is literally on the corner of a major intersection. And a homeless man who I had seen on the street several times and said hello to. We often chatted about life in general, but on this particular Friday evening, as I was getting ready to walk out the door, it was the coldest night we had coming up for weather-wise. We were facing the coldest night of the year. And he came up my steps, literally shivering, saying that he had been kicked out of his residence, that he had no place to go, was literally shaking through this conversation and worried that he was going to freeze to death that night. I set about making a series of phone calls to crisis centers, and I was unfortunately unable to get anyone. So I took the money that I had in my pocket, gave it to him, and asked him to go to the Cumberland Farms next door, get himself something to eat. And then I drove to the house of a person that I know runs our local crisis center. The good news is she was able to get him a bed for the night and then subsequently into the Veterans Administration because he had serious medical issues that needed attention. So not only did he eventually get to where he needed to be, but the frustration that I had in trying to reach somebody at the call centers is a direct result of them just not having enough resources to have them manned 24/7. The first section of this deals with that by asking that $125,000 be donated to the Department of Mental Health for the purpose of increasing those call center responses. The second section has to do with the headline of the article is Zero Suicide Program, but there's a lot more to that conversation. We are asking in section 2 to have $400,000 appropriated to the Department of Mental Health for two separate portions. One to go to expanding the Vermont Suicide Prevention Center's Zero Suicide Program throughout the state. And if you're not familiar with what that is, I would simply suggest that you Google Zero Suicide Program in Vermont, and you'll be able to watch an 11-minute video that is specifically targeted at legislators to learn about the program and what their needs are. The second section is that the money might be also shared to coordinate statewide suicide prevention efforts. This is a subject that is near and dear to me. I've spent the past 20 years or so as a motorcyclist riding with a group of motorcyclists around the North American continent. And we have all become very good friends and had the ability to enter into each other's lives in a way that most people don't. Suffice to say, it was a very bonded group of individuals. And one of them, who was a veteran, decided to take his own life. And it had an impact on all of us as well as that individual's families. The problem, especially with veterans, is something that I think we are only beginning to get hold of. We all understand that there is a problem. It doesn't take a rocket scientist when reading an obituary to learn, not just in the case of veterans, but in the case of any individual, when you're reading an obituary and you have no explanation of what happened to them, with respect to their death, the chances are pretty good it is either a overdose or a suicide. In the case of many of the overdoses, they are also suicides. So how do we get a handle on that? Well, the answer is to try to get some money into these programs that are trying to assist. This coordination effort is really a unification effort to learn what works and what doesn't work with respect to the multiple approaches that people have been taking, and try to utilize as best we can whatever resources are available in those things that do actually work. And finally, in Section 3, there is a request for $50,000 to go to the Department of Disabilities, Aging and Independent Living, or for the purpose specifically of improving the elder care clinician program, or to the vet-to-vet visitor program, or both. I think most of you are probably already aware of Dale's elder care clinician program. I'm not going to expand on that here, other than to say we're all getting older, and eventually we ourselves may be interested in partaking of some of these services. But I did want to talk a little bit about the vet-to-vet program. It is a national program that is a consumer-provider partnership that utilizes veterans themselves in the recovery in a peer counseling capacity to help other veterans. Officially, there is a 6-week peer facilitator training program that teaches veterans how to facilitate peer group sessions and introduce program learning types. So the idea of getting veterans themselves to help each other is a very worthwhile program to address what I see as veteran suicide. And hopefully we can get some more money donated to that cause. I'll close with the thanks, I guess, for the members of this committee that joined on to this piece of legislation. I do think it's an ideal time to spend money in these areas. This is somewhat out of my comfort zone because I don't usually come to the legislature and ask for money to go to certain programs. That's just the nature of how I ran as a Republican. But these are worthy programs, and we have a very pressing need at this point in time. And I think it was George Aiken who said it best: if Vermonters can't help Vermonters, what's the reason we have government? I'll end it with that and be happy to answer any questions.
Thank you, Senator Benning. That was great. Any questions from folks? I know we'll have to get some testimony on the details of all the programs and the content of the bill after we go through it with Katie. So, Senator Hardy.
Thank you, Madam Chair. Senator Benning, since this bill was introduced last year, are these amounts still accurate? I think I heard something that there may be something in the governor's budget about suicide prevention. And so I'm assuming that these numbers may be updated. Is that
yes,
correct?
If I had any critique of his presentation yesterday, I was hoping he was going to mention my name in my bill. But there are numbers that are currently designated in that budget presentation. I have not updated myself, Senator, to figure out whether they match what's in this bill. The bill is a placeholder, if you will, to get the conversation going about what should be done. And thank you for your question, because it reminds me that the last section of the bill had a effective date that needs to be changed as well.
Right. And just to put a thank you, Senator, just to put a bookmark in on possible witnesses, I think it would be helpful to have the Adjutant General come in and talk about efforts that he has been doing with the National Guard. I've talked to him several times, and he's part of a national group working on suicide prevention for National Guards and veterans. So I love to hear that, Senator Terrancini.
I'm trying to figure out which one of us is it.
I know. Who has the question? Who has the question?
It's wonderful.
Ruth, would you mind getting Senator Hardy, getting that contact information? And Senator Benning, I might ask you also if you have specific recommendations for testimony We'll sort it out. We're pretty good in here about knowing who's who through.
Yeah,
program.
I can say right off the bat, Senator, that the administration does wish to participate in this conversation.
Well, we will welcome them.
Come in.
Okay. All right. Thank you. Senator
Thank you all.
Terenzini, you have a question. Hold on here. We got you.
Sure.
One more question.
No, I appreciate you calling on me, Senator Lyons. Sorry about the little one there. He was frustrated. He couldn't get the Dunkin' Donuts in his mouth. So, Senator Benning, thanks for advancing this. It's mornings like this that remind me why I ran for the Senate to start with, and that's for good legislation like this. And thank you, Senator Lyons, for us discussing it, and hopefully we can make some headway with it this back half of the session, because it's critically important. It seems like we're hearing more and talking more about suicide and what we can do to prevent it, especially in light of the pandemic. And so I'm thrilled that we're going to discuss this.
Terrific. Senator Hooker.
Thank you, Senator Lyons, and thank you, Senator Benning. I just want to add my thanks, and especially thank you for including elders, because we hear a lot about suicide among young people and veterans, but sometimes we forget that people who are elderly enter into those dark spaces, and I appreciate that. Thank you.
I would say, especially during these times of COVID,
Yes.
the elder
Yes.
population is very lonely, and that's a critical issue right now for us to be addressing.
All right. Thank you. Thanks so much.
Thank you all. We'll see you on
all
the
right.
floor.
Oh, yes.
That's right.
All right, Katie, I'm going to, what we have in front of us is about 45 minutes left, and we have two other bills. These two bills, I think, are the ones that really need a little more in-depth presentation at this point. So let's go through those two bills, and then hopefully we'll have a half an hour left or close to it to go through the bills that Jen will be helping us with, the other two, S74 and H153. But Katie, thanks for being here.
You're welcome. Katie McLinn, Office of Legislative Counsel. Welcome back. It's nice to see everyone. I will go in the order that the sponsors presented. So I'll pull up S91 first.
Okay.
All right. Are you seeing what I'm seeing, S91?
We got it.
Great. So this, as Senator Wessman said, is the Parent-Child Center Network bill. As he mentioned, there's already language, there's a chapter in statute dedicated to the parent-child centers. So this bill updates that chapter. So we're focused more on a network than individual centers. And you'll see that the title changes on line 16 and lines 18 and 19 reflect that change, that we're talking about a network and not individual centers. So first, the definition of parent-child center is the proposal is to update it to mean a community-based organization that serves as a central hub and lead provider of primary prevention services for families with young children on behalf of the state. And this section also adds a definition of the parent-child center network, which means an AHS community partner composed of designated parent-child centers that ensures accountability and collaboration among designated parent-child centers. In subsection B, we're pretty much striking out most of the language here at the introduction of subsection B. And there's new language being added that shows how the network can be expanded. So this language says that the network can recommend to the Secretary of AHS or designee one or more new parent-child centers for designation every 6 years. And upon receipt of this recommendation from the network, the secretary or designee is to review each center that's recommended by the network for designation to ensure that it meets the criteria that is set forth below in subsection C. And that a parent-child center that's recommended by the network and determined to meet the criteria that we'll look at next is to be deemed by the secretary or the secretary's designee to be to be a designated parent-child center and part of the network. So subsection C This is the criteria for designation. And you'll see some of the language in subsection C is not underlined. So this is existing law. Receiving funding from one or more private, local, federal sources, qualifying for tax exemption under 501c, and then having a parent representative on its board of directors representing designated geographic catchment area. That's all an existing law. But the new criteria begin on line 15. So that is completing a peer review every 3 years, which is to be conducted by the network, providing each of the 8 core services that we'll look at next in subsection D, indicating an intent to participate in the network as a member, and lastly, working to achieve population level quality of life outcomes related to children and families. So those are the criteria. One of the criteria, as I mentioned, was having one of the 8 core competencies. So that language is set forth below in subsection D. So here we have the list of the core competencies that each designated parent-child center would have to have in order to be part of the network. So a designated parent-child center would do home visits, provide early childhood services, provide parent education, host play groups and parent support groups, offer concrete supports, provide community development and resources and referrals. So those are the 8 core competencies. And then there's a clause that says that any parent-child center that was in existence last year, January 1, 2021, is deemed to have met the designation requirements. The next section has to do with funding and how sort of the mechanism for funding works for the network. So in subsection A, the secretary is to annually disperse a joint appropriation for all of the parent-child centers to the network. And it's the network that would be distributing the funding to each parent-child center. And then any increase to base funding would be based on community need, provision of additional services, or the designation of a new center. In subsection B, the network is to work in partnership with AHS to develop appropriate measures of accountability and to provide any financial or programmatic information as necessary to enable the secretary to evaluate the services provided through grant funds and the effect of the services on consumers and the accounting of the expenditure of grant funds. And then lastly, there's language in subsection C that in determining the annual appropriation for the network, the secretary is to employ an annual inflation factor. And the guidelines there, the inflation factor is reasonable and adequately reflects economic conditions. And then you have an appropriation. This bill was introduced last year, so this appropriation is for fiscal year 2022. So if you were to move forward, this would, of course, have to be updated, but it was 7.5 million in fiscal year 2022 to the network. And then effective date again would have to be updated if you moved forward with this draft. So that is the first bill.
Okay, let's just pause for a second. I don't want to get into a discussion around the various sections of the bill until we've had an opportunity to hear testimony, but your presentation is pretty clear. So it would allow for the parent-child centers to be part of a broader network, both in the state and then nationally. So we will, and the appropriation piece is something that all the money ends up down the hallway, but we'll, so we'll take, unless I hear differently from folks, we will probably follow through with some testimony on this bill and look to see how we can make improvements if necessary. Any questions of clarification? All right, good. Katie, back to you.
Okay, pull up S69.
Your
So
voice,
Jane-
your sound just went down. I don't know why. Maybe it'll come back as you speak. We'll try
Can
it.
you hear me?
Very little.
You can't hear me?
Yes,
I'm
we
not
can.
muted.
Keep going.
Okay.
It'll come.
I'm not muted. I'm not sure what's happening.
There it is. No, it happened before. It just, it takes a minute to get back up. So
Okay.
let's see what happens.
So are you seeing S69? I might have to stop share and restart. Oh, it
We're
did.
good.
Okay. You're good. Great. So Senator Benning did most of my work on this bill, but as he described, this bill is a series of sections. Each section has an appropriation for a different program aimed at suicide prevention. As he also noted, this bill was introduced last year, so all of the appropriations are for fiscal year 22. And if you chose to move forward with this bill, you'd have to update the fiscal years and possibly the amounts. So the first section is the Vermont's National Suicide Prevention Lifeline. So this was an $125,000 appropriation for fiscal year 2022 to the Department of Mental Health for the purpose of increasing the in-state call response at Vermont's local crisis call centers to 70%. The next appropriation in section 2 is for 2 programs. So in fiscal year 2022, the appropriation is for $400,000 to the Department of Mental Health. The first program that this appropriation would be for is for the Suicide Prevention Center's Zero Suicide Program throughout the state. And that program is a system-wide framework to prevent suicide among individuals under the care of the health and mental health systems throughout the state. And the second program under that 400,000 would be appropriated for is establishing a new position, a full-time position that would be shared between the Departments of Health and Mental Health to coordinate statewide suicide prevention efforts in coordination with the U.S. Department of Veterans Affairs. And lastly, there's a $50,000 appropriation in fiscal year 2022 to Dale for the purpose of expanding the elder care clinician program or the vet-to-vet visitor program, or both of those programs. And as Senator Benning said, the vet-to-vet visitor program involves veterans being paired with aging or disabled veterans to meet them in their homes for multiple visits a month, 2 to 3 visits a month. And then last, we have an effective date of July 1, 2021, which would need to be updated if you chose to move forward with this piece of legislation.
Okay, thank you. This one is, it has a lot of money in it. So one of our job is going to be to evaluate the policy that's in here. And I'm going to suggest that we have some other bills in the committee that have recently been introduced. Senator Hooker and I and others have put some bills in, and I'm thinking that it might be helpful for us to go through those bills as well and to see if there's some integration that we can make, and that instead of, but my concern is if a bill doesn't require an appropriation, we may not want to have to send it to appropriations. So we'll take a little time to look at the bills that have come to us around mental health issues, and then we can have that discussion together after we've gone through those bills as well. But this one, certainly mental health at every stage of life is pretty much of an emergency right now. So just we'll go with that. Any questions of clarification at this point? All right, good. Yes, no, Senator Benning did your job, Katie, but you did it. You're the only one who can do your job. All right. So Katie, thank you. And help us identify some of the legislation that we have in our committee that we might look at concurrently with S69. Not that we want to put them all together, but there might be some pieces that fit. That would help in all of your spare time. Okay, good. All right, we'll move on. We're on a good trajectory of time. So Senator McCormick is here, and we'll move on to the next bill, which is S-74. And Senator McCormick, I'm asking you to be as concise as possible. After you have testified as lead sponsor, then we'll have Jen Carby go through the bill more specifically.
Thank you, Madam Chair. I like to think I'm always concise. I'm, for the record, Senator Richard McCormick, doing business as Dick McCormick. I'm a former member of this committee, actually 2 go-rounds over the years, and chief sponsor of S-74. I've submitted written testimony, and my spoken testimony will follow that outline, although I'd rather not read what you already have in front of you. S-74 makes technical changes to Act 39, which is the now the existing Vermont law providing medical assistance in dying. When we passed Act 39, it was a fairly innovative law. There was not a lot of experience to look at. And we relied heavily on what was then the existing law in Oregon. When Oregon passed their law, they had nothing to look at. And a good deal of the Oregon discussion, pro and con, was conjectural. The advantages of the bill were conjectural, and so were various anxieties about possible problems. And remedies were conjectural. The Oregon law, which Vermont used as our model, is rich in safeguards against possible abuses. We now have, I think it's 11 states with similar laws. Oregon goes back to the 90s. This has been the law in Vermont for many years. And we now have solid realities to look at and base on which to base the law. What this bill does is it addresses 3 areas of Act 39 that have been demonstrated to be unnecessary and burdensome for dying people who try to use the law. The first change that the bill would make has to do with telemedicine. When we passed this law, telemedicine was an idea. It was an innovation. Now it's boilerplate. It's how it's often done. I had the privilege as a member of this committee of speaking on the floor about telemedicine as a response to COVID, for example. The law as it is presently written requires that a request from a dying person for a prescription be made in person. That is an anomaly. Telemedicine is now frequently used. The usual procedure there are times when telemedicine is probably not appropriate and where an in-person meeting with patient and doctor are necessary. And the standard procedure is that that's up to the doctor. And were this to pass into law, the doctor would still have the option upon an electronic communication of saying, I think I need to see you in person. But this allows for that. This makes the law under Act 39 consistent with usual medical practice, which is that the doctor would decide whether or not telemedicine is acceptable or not. The second provision has to do with that the present law has a fairly long procedure to obtain a prescription and includes a 2-week delay just to make sure that the patient is not acting hastily. And the present law requires that after the 2-week delay, there's an additional 48 hours. And this bill would remove that 48-hour additional requirement. Finally, the bill makes explicit what our Attorney General says is implicit in the law. And it is this: the present law as written provides protection for doctors who participate in medically aiding, medically hastening death. It does not explicitly provide those protections to pharmacists and other healthcare givers. And S74 would make explicit what is already implicit. And this is not a technicality. One could say, well, if pharmacists are already covered, there's really no problem. The problem is that the pharmacists don't are not confident in that implicit protection. The feet on the ground reality is Vermont has one pharmacist who will prescribe, and then there are nearby pharmacists in New Hampshire. So that the access to this benefit is impeded by the three provisions in law that the bill seeks to address. And I'll answer questions, or I'll go back to my morning committee.
Thank you, Senator. That was very clear. And as you said, you're always concise.
Always.
So questions for Senator McCormick as lead sponsor of the bill? And Senator McCormick, we know that you have worked on this issue for many years and appreciate your consistent support of the work in the legislature on this.
Thank you.
And you and I have worked together. I think my first session, I worked on this with Dick Walters, and now
Yeah.
he is no longer with us. So
Right. And I should mention Claire Anger. She was chair of this
Yes.
committee when we did this. And
yeah, she was.
Yeah.
It's been a handoff consistently, and it's been a good collaborative process. I do want to say, and I think you did say this or imply it at least, that this bill is about fixing what we already have in place. It's not about validating or putting in place our current program. Okay, so let's move on to Senator. I'm going to say thank you and take care of the natural world.
we'll try.
All
Bye.
right. Jen, thanks for being here this morning. And I guess we'll just dive into looking at S74 and going through its provisions briefly. And then after that, we'll move on to our next bill.
Great. Well, good morning. Jennifer Carvey from the Office of Legislative Counsel, and I will put the language up on the screen. I think. Let me find where I've hidden it. All right. Can you see the S74 language of S74?
No, we have
No.
some statutory language up
Well,
on
that's
healthcare
unfortunate. All right.
facility definition.
Oh, well, we're in that same statute, but I'm for whatever reason having trouble finding here we go. Now can you see it?
Yes, thank you.
Oh, good. All right. So this is S74, and I think Senator McCormick did a good job of walking you through what the provisions are, but I will show you what they look like in context. And as both the chair and Senator McCormick mentioned, these are changes to an existing framework that has been set up for allowing patients to request medication, certain patients to request medication for the purpose of hastening death. So in the first section here, we're looking at the requirements for the prescription and documentation, and the way this law is set up. It's really done through the lens of the physician who would be doing the prescribing. And so it talks about the types of things that the actions that the physician must take in order to not be subject to any civil or criminal liability or professional disciplinary action for prescribing this medication. And so the first changes here deal with, as Senator McCormick said, whether the oral request from the patient must be made in the physician's physical presence, or whether it could be done in another manner, such as telemedicine. And so in this case is striking through two requirements that the oral requests, the first one and the second one, that must be at least 15 days after the first request, be done in the physician's physical presence. Similarly, it would eliminate a requirement that the physician's examination of the patient to determine that the patient was suffering from a terminal condition be based in part on the physician's physical examination. So the examination would not need to be a physical examination, could be done through telemedicine or another means, and the review of the patient's relevant medical records. And finally, in this section, they would eliminate the 48-hour delay requirement for the physician writing the prescription, which under the current law, and this is actually why I had this language up on my other screen, it requires the physician to have written the prescription after the last to occur of 3 events, those being the patient's written request for medication, the patient's second oral request, and the physician offering the patient an opportunity to rescind the request. So those would all still be there, but this would get rid of the 48-hour delay between the last of those events to occur and the physician writing the prescription. And then the second section of the bill would add some specific language to an existing provision on limitations on actions that would say that no person shall be subject to civil or criminal liability or professional disciplinary action for acting in good faith compliance with the provisions of this chapter. So under the existing law, there are some other provisions on limitations on actions, one specifying that physicians, nurses, and pharmacists and anyone else is not under any duty, cannot be under any duty by law or contract to participate in providing medication to a patient under this chapter, and specifying that a healthcare facility and healthcare provider cannot subject a provider to discipline, suspension, loss of license, loss of privileges, or other penalties for actions taken in good faith reliance on the provisions of the chapter or refusals to act under the chapter. This would add language saying that nobody would be subject to civil or criminal liability or professional disciplinary action as long as they were acting in good faith compliance with the provisions of this chapter. And it would take effect on passage.
Okay, thank you, Jen. That was
Sure.
really clear. The combination of Senator McCormick's explanation and going through the bill is very helpful. And it does remind us that there are other conditions surrounding some of each of the 3. So that's also helpful. Questions for Jen, clarification? Obviously, we have questions about data that supports making these changes, and we'll get testimony in that will help us understand why the requests are being made. Okay. Wow. We're good. So unless I hear differently, again, this is a bill that we would like to hear more about, and we'll move forward on that. Okay. And then as we're going through these bills, I know that they are, they're near and dear to all of us, or at least some of us, each one. So think about how you would like to participate in this. And if you're willing to present the bill on the floor, that's something we'll be asking going forward. All right. So we have some esteemed House members here with us. Thank you for being here. We're going to be taking up H-153, which was passed at the end of the session last time. And I just want to say up front, H-153 is something that we'll look at. I'm not certain that it's going to be going out of the door really fast, because there might be some additions, subtractions, and amendments that we can make that would expand it a little bit, but we'll see how that goes and what the committee thinks after having testimony. But thank you, Representative Noyes and Representative Woods for being here. Why don't you two present the bill as the lead sponsors?
Sure. Good morning, and thank you, Madam Chair, for taking the time to let us talk about this bill today to the committee. So this is a bill that Representative Wood and I have been working on for a number of years, and we were glad to see it pass the House and end up here in Senate Health and Welfare. So pretty straightforward in terms of looking at the Medicaid reimbursement rates for home and community-based service providers, so that there's a level of predictability in how much it costs to deliver these services to older Vermonters and individuals with disabilities in Vermont. The bill does not allocate any funds. It mainly just looks at what it costs and asks the department to work with the agencies to come up with the actual cost to deliver these services, so that down the road we can make sure that our investments are where they need to go to help the most amount of people. I will turn it over to Representative Wood to say a few words and see if the committee has any questions.
Thank you, Representative Noyes, and thank you, Madam Chair. And we are delighted to hear that your committee will be taking up the bill. And I think that one of the things that we have all experienced during this pandemic is an acknowledgement that our human infrastructure is crumbling underneath us right now. And I'm not being overly dramatic about that. We have our community providers. We have 3 nursing homes that are on the verge of bankruptcy. We've had 3 adult day programs that have already closed and removed those services from individuals in those areas. We have our designated and specialized service agencies talking about needing support from the National Guard to ensure the safety of Vermonters, because they don't have the funds to be able to pay the wages that they need to attract people in this day and age. I heard from the Washington County Mental Health Executive Director the other day that they're considering closing one of their group homes because they can't ensure the safety of people who are living there now. We cannot afford not to do something. I know that's a double negative, but we have addressed issues for this group of providers, but I have to say it's been in a helter-skelter sort of way. It's been in a way that has not had any predictability, has not been based on our knowledge as a legislative body of what the true costs are of providing those services. It's been based upon, legislative advocacy for it, it to be the truth of the matter. And we are at the point where we can't really have our heads in the sand anymore if we want there to be a system of long-term services and supports for people post-pandemic. As Representative Noyes said, this does not allocate any specific funds, but it sets out a process where the Secretary of Human Services, the ultimate person in charge there, has to present to us each year what the true cost of these services are. And it leaves it up to us to decide, whether or not we are able to incrementally chip away at those service costs. It also provides the information to the Secretary. And the Secretary doesn't have that information right now, quite frankly. And so, we haven't seen budget requests on a routine basis other than for nursing homes, because that's already in statute. For all of the rest of the home and community-based service providers who are out there providing tens of thousands of Vermonters these services. And I have to say that I'm really fearful for this system right now. And I just wanted to express that and to express our appreciation to the Senate for taking up this bill. And we're here to answer any questions that you might have from the House perspective. We can't hear you, Madam Chair.
Thank you for that. Thank you both for advocating for the bill. and what's in the bill. I know we all hear from our long-term care folks, from our SASH and Choices for Care folks. We know that there is a great need in our communities, and when we visit these facilities, we can see for ourselves. So I do have a question, and then I think what we'll do is we'll turn it over to Jen Carby to go through the bill. You did not, did you have, I think there is a fiscal note for the bill somewhere. True or false?
This bill did go through our Appropriations Committee, Madam
Okay.
Chair. To be honest with you, I don't remember if there's a fiscal note or not.
All
But
right,
it did go through our
yeah,
Appropriations Committee.
I did talk with Nolan about it, and I think there might be one somewhere, but we'll go back to Nolan Langwell and or JFO and see what's there. And
It
then,
could be-
so just an FYI for you, I think that this is something that resonates with a number of us sitting here. But there are other areas that are very poorly determined. The data is insufficient, and other areas for reimbursement or payment that we're concerned about. I don't know whether we'll integrate any of that into this bill, but we'll certainly take some time with it. My other question for you, and this is something that as you go through the Budget Adjustment Act, you may want to consider what funds are available to support some of the work that you're seeing here. Is there something in the, there's something in federal dollars that can begin to move this forward? That's just a question that you can take back to your Human Services Committee, because I think that you're deeply engaged in that right now.
Yes, we will.
We
Thank
just
you.
We just left that discussion to come.
Yeah.
Oh, good. Well, then you need to get back there. Questions of clarification from the committee? Senator Hardy?
Thank you, Madam Chair. And I'm just looking at the definition of home and community-based services, and maybe I'm sure Jen will cover this in her, but I'm just wanting to make sure I understand what this encompasses, like which areas and who's in and who may be left out.
So I'm going to suggest we put that question to Jen.
Okay.
And yeah, that's a good Jen question. And then I know that both Representative Wood and Noyes probably can answer it, but I think moving into the bill, we'll get that question answered.
I would actually recommend that because Representative Wood has such a deep background in this area, she may actually be the best one to answer it. I can do my best,
all
but
right, go for it.
I think she will do a better job.
I agree.
Oh, okay.
Thank you, Madam Chair and Ms. Carby. For members of the committee who might not know, I was formerly the Deputy Commissioner at the Department of Disabilities, Aging and Independent Living. So I believe that's what Jen is referring to. The definition of home and community-based services is specific in that it is including things that are not under the Global Commitment to Health, the GC, but that also are home and community-based services. So ACC, Assistive Community Care Services, for instance. Adult day rehab is a Medicaid service, but it's not under the Choices for Care program. So typically when we refer to home and community-based services, people think of Choices for Care, or they think of the Developmental Disabilities Waiver. So we wanted to be explicit that the home and community-based services really encompassed all of those services that we consider to be provided in the home and community, not just those contained under the Choices for Care waiver.
Got it.
So can I just ask a clarifying question?
Please do. Yep.
So does this also include mental health and designated agencies or not? Yes, it does.
Yes, it does.
And then home health and hospice and adult day. Okay. And whether they're provided, is it, sorry, but I'm just trying to get
It's okay.
sense
Go
of the
ahead.
universe in home. So if somebody is getting home health and hospice services in their home, that would be covered under this framework. What about if they're getting services in a long-term care facility?
A long-term care facility that is not a nursing home.
That is
So-
not a nursing home.
That's correct. So we have residential care homes, enhanced residential care homes. Those would be included. We did not include nursing homes because they already have in statute a provision for review of their rates and a process to do that. I will put a plug in though. I think that needs to be revisited at some point, but because it's far too retrospective, and we've learned that in this pandemic that it needs to be a bit more nimble than it is. But the way the bill is written, it did not include nursing facilities specifically because they already have statutory language referencing that.
Mm-hmm. Okay.
And it also includes providers of substance use disorder treatment. You'll
Yes.
see that on page 5.
Oh, great. Okay. Thank you.
So, you know what would be extremely helpful, Representative Wood, as we get testimony on this, is there, perhaps you could share with us some folks that you find very helpful in elaborating on the list that you just gave us, so that we understand what the discrimination between what's in and what's out.
Yes, we can absolutely do that.
Terrific. And you could send that to Aaron, our assistant, send it to me and I can forward it if that doesn't work. Great.
Will
Thank
do.
you. Yeah, no, this is great. And thank you for your work on this. Thank you both. I know you're both strong advocates in this area and I appreciate it.
Okay. Thank you
All right.
very much. And we look forward to hearing from you.
Okay,
Thank you.
take care. All right, Jen, we'll go through the bill.
Okay, great. And I did find and send to Aaron with confirmation from Nolan the fiscal note. So that is now should be getting posted on your committee page.
Terrific.
All right, so I will put up more smoothly than last time the bill so we can walk through it. This is H-153, an act relating to Medicaid reimbursements for rates for home and community-based service providers. And so this is the words version of what you just heard described by the members from the House Human Services Committee. It starts by creating a new definition. So adding a definition in an existing definition section in Title 33 for home and community-based services. And this is getting at what Representative Wood was describing. The definition is long-term services and supports provided to older adults and adults with physical disabilities in a home or community setting other than a nursing home, including enhanced residential care services pursuant to the Choices for Care component of Vermont's Global Commitment to Health, Section 1115 Medicaid demonstration or a successor program. We're just going to call that Choices for Care. So pursuant to Choices for Care. And it also adds to that for this definition, home and community-based services also includes non-choices for care, home health and hospice services, adult day rehabilitation services, assistive community care services, and services for individuals with traumatic brain injury. So that's our definition that we're going to use in this next section for home and community-based services. And it adds a new section in this chapter on payment rates for providers of home and community-based services. It directs the Secretary of Human Services to determine payment rates for providers of home and community-based services that are reasonable and adequate to achieve the required outcomes for the populations they serve. And I'll pause here for a moment. You'll see in the next section that we look at, it's doing the same thing for payment rates to the designated and specialized service agencies. That was actually a provision that was added to the statutes a few years ago. And so this is built on that kind of a model with some additional provisions and some requirements to have that happen. I think the framework was set up for the DAs and SSAs, but it has not happened yet. So these will be consistent provisions for the home and community-based service providers and the DAs and SSAs. So it requires the Secretary of Human Services to determine payment rates for these providers that are reasonable and adequate to achieve the required outcomes for the populations they serve. And when determining the payment rates, it requires the Secretary to adjust the rate amounts to take into account factors that include, doesn't have to be the only ones, but that include the reasonable cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal authority, and a cost adjustment factor to reflect changes in reasonable costs of goods to and services of these providers of home and community-based services, including those attributable to inflation and labor market dynamics. When determining these reasonable and adequate rates of payment, the Secretary may consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. Then directs the Secretary to adopt rules setting forth the methodology for determining the payment rates for providers of home and community-based services in accordance with this section. And the rules must include a process for determining an annual inflationary rate adjustment. They must set forth a predictable timeline for redetermination of base rates, and they must use Vermont labor market rates and Vermont costs of operation. Then directs the Secretary to redetermine the payment rates for providers of home and community-based services at least annually, and report those rates and the amounts necessary to fund them to the committees of jurisdiction, including this committee, annually as part of the agency's budget presentation. So just to recap a little bit, requires the Secretary to determine the rates, including certain factors that must be taken into account. It requires rules with a methodology for determining the rates, including a process for an annual inflation adjustment, timeline for redetermining base rates and using Vermont information, and then requires the Secretary to redetermine the payment rates at least annually and provide the rates and the amounts needed to fund them as part of their annual budget presentation. We then in section 3 have similar provisions for payment rates to the designated and specialized service agencies we refer to as the DAs and SSAs. So it makes the language align with what we just saw in section 2, still having the Secretary determine the Department of Health, Department of Mental Health, and the Department of Disabilities, Aging, and Independent Living rates of payment for the DAs and SSAs, again, that are reasonable and adequate to achieve the required outcomes for designated populations. And when determining the rates, the Secretary would adjust the rate amounts to take into account factors that include reasonable cost of governmental mandates and a cost adjustment factor reflecting changes in reasonable costs of goods and services, including those attributed to inflation and labor market dynamics. It again allows the Secretary to consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state, and then directs the Secretary to adopt rules setting forth the methodology for determining the payment rates for services provided by the DAs and SSAs to individuals with mental conditions, individuals with substance use disorders, and individuals with developmental or intellectual disabilities in accordance with this section. And these rules, like the ones for the home and community-based service providers, would include a process for determining an annual inflationary rate adjustment, set forth a predictable timeline for redetermination of base rates, and use Vermont labor market rates and Vermont costs of operation. And then again, the Secretary would be redetermining these payment rates at least annually and reporting them and the amounts necessary to fund them to the committees of jurisdiction, including this committee, annually as part of the agency's budget presentation. Section 4 calls for a report, a rate study and report. This directs the Department of Vermont Health Access in collaboration with DALE, Department of Health, and Department of Mental Health to conduct a rate study of the Medicaid reimbursement rates paid to providers of home and community-based services and providers of substance use disorder treatment services. And my understanding is there was one done for the DAs and SSAs, except those that provide substance use disorder treatments. So this would be for those that had not had a rate study done, including the adequacy of the rates and the methodologies underlying them. And as part of the rate study, DVHA is directed to delineate a reasonable and predictable schedule for Medicaid rates and rate updates, identify ways to align Medicaid reimbursement methodologies and rates for providers of home and community-based services with those of other payers to the extent those other methodologies and rates exist, and determine ways to limit the number of methodological exceptions. This bill was considered last year, and so it has a date that would need to be changed, but currently says on or before January 15th, 2022. DEVA, in collaboration with those other departments, would report the results of its rate study and their findings and recommendations to this committee and other committees of jurisdiction. And then finally, the act would take effect on passage with the rules adopted by the Secretary of Human Services to create those methodologies for the home and community-based service providers and the DAs and SSAs, taking effect on or before a date certain. In this case, again, it was considered last year, so it would have been for July of this year.
Okay,
Yeah,
thank
just
you.
move.
There's actually a lot in here, isn't there?
Yes.
I do have one specific question, Jen, and that is there anything in the bill that asks for a look at any costs mitigated for the patient as a result of reimbursement rate increases? Is there anything in here that if there's an increase for the private sector, does that mean that patients will be paying a higher premium to cover that? Is there anything in there that looks at the effect on out-of-pocket or premium costs?
Well, this is all focused on Medicaid reimbursement rates. And so these are Medicaid beneficiaries. So generally, they do not have out-of-pocket requirements for the services.
But then there is a
understanding the
section,
question.
there is a section on looking at comparison with private. Okay,
Right, that's really on looking at identifying ways to align the reimbursement methodologies and rates for the providers with those of other payers if they exist. So looking at how reimbursement works
yeah, okay.
for
All
other
right,
payers,
I
but
just
not
don't want to,
necessarily.
I just don't want to lose sight of the fact that we have the big pay down for access to services. Some people have to use up savings sometimes. So just don't want to lose sight of that. Somehow that fits in that with my thinking, but maybe not. Okay. Questions for Jen? Go ahead, Senator Hardy.
Thank you, Madam Chair. So Jen, there's a process for determining the need and then a process for the secretary, I'm making the oversimplifying, but then the process for the secretary to make essentially a budget request to the legislature saying this is how much this services cost. Is there any ramifications if the secretary one doesn't do that, or if the legislature doesn't act and fully fund the need?
I mean, the requirement for the secretary to do the work is sort of the same accountability provisions that there are for all of the directives to the administration, which is effectively you've directed them to execute the laws and they have a duty to do that. So if they are not complying, that may be something you want to take up with them in a various forums to ask that to occur. There are potentially some legal remedies ultimately that could be done if they didn't, but typically that is the recourse is for you to make an issue of it if they're not doing their job. As far as whether there is any, what the ramifications are if you don't fund it, there is not a requirement. I think originally in earlier versions, there either was language or was contemplation of making this actually happen. And there was some discomfort expressed on particularly the appropriations side about anything that would lock in or create an entitlement or expectation of funding amounts. So it has become more of an informational role, but with making that, teeing it up for a conversation at the legislature about what the appropriate amounts would be and how much to appropriate for them.
Okay. And then sort of along the same lines as the question the chair just asked, some of these services, I think, are, or maybe not, paid for by Medicare. Is that true? Are any of them partially Medicare covered services? Senator Cummings is shaking her head, so maybe not.
That is a question we would need to ask somebody else. I'm not sure the extent, because it's a federal program. I'm not sure the extent to which there is would be overlap, but I think for the most part, these are not things that are would be Medicare funded. If they were, that how those were paid, I think would be handled either solely by the feds, or Dale may have some idea of how the money shakes out there.
Okay, should have asked Representative Wood. She probably knows. All right.
Well, yeah, we'll get testimony and try to clarify those questions. Are good questions.
Right. Medicare does seem to be more strict medical, sort of physician and hospital expenditures, and with Part D prescription drugs, but less home and community-based type services.
Whether our waivers can allow for some of this. So those are good questions to ask. Any other questions for Jen? Okay, Jen, thank you so much. And this is one we're going to have to look at, and I think look at a little bit gradually. It is a House bill, so they've been through it, but if we're going to add something to it, we certainly want to act on it before crossover. So keep an eye out, and you're thinking caps on for reimbursement changes and what other analyses might fit into this as we go through other bills. So we may or may not change this bill. It might go just, it's like any other bill, but okay. Ina Backus will be coming on with us to talk about workforce and the workforce report that was in, I think it was, I forgot, Act 155. Anyway, so I'm going to suggest, Aaron, I don't know if Ina is not yet in the waiting room, that we take a 5-minute break. We'll start again exactly at 10:30. We can go offline for a couple of minutes. And Aaron, maybe you could communicate with Ina about our time frame, and we'll begin exactly at 10:30.